Three, two, one. We are live now, man.
Shweta, are you going to start? Who's going to start?
Today I'll start, sir.
Yeah, please go ahead.
Very good evening, everyone. A warm welcome to all of you to the fourth episode of Blood, the Life Savior. It's a truly wonderful to see the growing interest and energy around this series. And we are grateful to have each one of you with us today. This evening, we bring you yet another thought provoking topic Hydra dual heads, unveiling the dichotomy of a disease, a session that promises to challenge perspectives and deepen our understanding of complex hematological conditions. Before we begin, it's my privilege to acknowledge the two stalwarts who have been the backbone of this series. Our course directors, Dr. Biju George, professor at CMC Vellore, a pioneer in bone marrow transplantation and globally respected clinician and scientist, and Dr. M. Joseph John, professor and head at CMC Ludhiana, a visionary who has transformed clinical hematology services and education in India. Their leadership, depth of knowledge, and passion for advancing care in bleeding and hematological disorders continue to inspire all of us. I would also like to acknowledge the brilliant panel from AIMS Kochi who will lead us through today's discussion. Dr. Gopal Sinhal Singh, a senior resident, will walk us through the case presentation. Dr. Gohul GJ, Assistant Professor, and Dr. Meera M, Senior Resident, will bring in their insight during the case presentations. And finally, Dr. Neeraj Siddharthan, Professor and HOD, will provide the summary and conclusion. We are thankful to the entire team for their contribution to this episode. With that, I now hand over the session to our esteemed course director to take us forward. Over to you, sir.
Thank you, Shweta. So this is the fourth episode that we have of Blood the Life Savior. And through this sessions that we have once a month, what we hope to do is to have a case presentation and a discussion which will highlight uh, both the disease as well as difficulties and management of the disease. We've had previous sessions on aplastic anemia, on iron deficiency anemia. So with that, we've got I would find a very interesting topic which Amrita has put up saying Hydra's dual heads. So we would love to hear more about it from Dr. Neeraj and his team. So over to you, Neeraj.
Thank you very much, Vijay sir, and thanks to the organizing team, uh, Dr. Joseph and Shweta and the rest of the team. And it's our privilege to be a part of it, and hope that we do justice to the fourth episode of Blood the Life Saving. So we had been able to choose a case which was diagnostically difficult. Also, it was a very challenging to manage this patient as well. So without further delay, I would request Dr. Gopal Sinhal, senior resident, to take us through the case. Gopal, can you please start? And then Dr. Gokul will discuss the clinical part of it, and Dr. Meera would discuss the laboratory aspects of the case.
Good evening, everyone. I'm starting my discussion. Today's discussion is Hydra's fuel dual heads, unveiling the dichotomy of the disease. We seen this patient as a consultation. Patient was admitted under liver ICU under hepatology department. Patient is a 48-year-old male. Name is XYZ from Kottayam. Salesman by occupation and history given by the wife. His chief complaint was generalized tiredness since 2 months, constipation since 1 month, vomiting since 1 month, fatigue since 2 weeks, and darkening of urine and yellowish discoloration of eyes since 2 weeks. Patient was apparently usual state of the health until the approximately 2 months ago when he began the experiencing the generalized tiredness. The fatigue was insidious in onset and gradually progressive, affecting his daily work and routine activities. He reported the feeling increasingly weak even after adequate rest, and these symptoms persisted throughout the day. About 1 month later, he began to experience the episode of the constipation, which were described as a infrequent and hard stools, associated with sense of incomplete evacuation, and he did not report any bleeding per rectum or altered stool color or passage of mucus. Around the same time, he also started having a multiple episode of non-projectile vomiting, which typically occur after meals. The vomitus was non-bilious and contained the food particles. There was no history of hematemesis, abdominal pain, or fever. Subsequently, he developed the fatigue that significantly worsened, along with darkening of urine and yellowish discoloration of eyes and skin for 2 weeks. The constipation also worsened around this time. There is a no associated pruritus or clay color stools or bleeding tendencies. Also, no history of any abdominal pain, distension, weight loss, or fever or night sweats. Then there was a no history of GI bleeding, chest pain, breathlessness, palpitation, or orthopnea. There is no similar complaints in the past and no history of recent travels or changing in diet or consumption of any contaminated water or food. There is also known case of the diabetes and hypertension since 1 year, and his history of alcohol consumption was there, but the details are not available. Details was not available. Then, in view of the above symptoms, he was evaluated in outside hospital by the gastroenterologist. His CBC was WBC 30,000, HB 9.4, LFT showing total bilirubin 10.27 milligram per deciliter. Direct was increased 8.71 milligram per deciliter. Alkaline phosphatase was raised 303, and USG show hepatomegaly, and RFT and coagulation parameters was within normal limit. He was further evaluated with autoimmune hepatic panel and viral serology, which were negative, and ANA show 1 plus positive. Then he further evaluated with MRI abdomen with MRCP, which show prominent periportal lymphadenopathy and rest normal study. In view of history of alcohol, varices, he was further evaluated with OGD scopy. It showed D1 nodularity with extensive bulge. And in view of worsening of symptoms, he was referred to the Amrita Hospital for further management. And patient was admitted under hepatology department in liver ICU. At Amrita Hospital, his lab show anemia. HB was 9.8 gram per deciliter. Total counts 20.2 20,000. Neutrophils was 40%. With LFT show total bilirubin was 21.94 and direct was 13.79. And transplantation was there. SGOT was 143 and SGPT was 66 international units per liter. Alkaline phosphatase was 404. GGT was raised 305. Urea was 39.2. Create was high 1.4. Ammonia was also high 196. And LDS show 562. Hypercalcemia was there 13.58. Hyperphosphatemia 4.9 and hyperuricemia 6.6. In view of anemia, hypercalcemia, and high LDH, hematology consultation was given. And our disease was lymphoproliferative disorder, any aggressive T cell lymphoma in view of hyperuricemia, multiple myeloma or plasmacytoma in view of anemia with hyperuricemia, or third DD was metastasis due to the any solid organ malignancy, non-hematological like that primary hyperparathyroidism or acute liver failure due to the alcohol. Then uh, further discussion will be done by the Dr. Meera madam.
So we received a, CBC with PBS sample for this patient. So initially the CBC value showed a total count of 20,200 cells and HP of 9.8 gram per DL. Subsequently, a PS was also received, which nearly showed 44% circulating large atypical cells, which are nearly 2 to 3 times that of a lymphocyte with high NC ratio, moderate basophilic agranular cytoplasm and coarse chromatin in a background of circulating NRBCs and left-shifted myeloid cells. So we kept a impression as a leukoerythroblastic blood picture with a 44% circulating large atypical cells, and DDs included, because of its large size, either a lymphoma versus leukemia was an initial DD. A subtle suspicion of circulating plasma cell was also thought of. So, but plasma cell leukemia was last in our DD. So again, followed by this, we received a marrow study. So again, the bone marrow aspirate again showed, which was aparticulate, hemodiluted. However, it again showed 32% of nearly 32% of atypical cells with plasmacytoid morphology, and it also again appeared 2 to 3 times larger than the lymphocyte with high NC ratio, moderate basophilic agranular cytoplasm and coarse chromatin and inconspicuous nucleoli. But in certain areas, a few cells looked similar to a plasma cells itself, which was having a cartwheel chromatin, eccentrically placed nucleus, and a perinuclear hub. But majority of the cells in this bone marrow aspirate morphology were not classical plasma cells, but looked like cells which have plasmacytoid morphology. So again, now our DD again confined to, again defined as, since the plasmacytoid morphology was there, we thought of differentials of a plasma cell dyscrasia. However, a possibility of lymphoma with plasmacytic differentiation need also to be excluded. So with these differentials in our mind, we performed a flow cytometry on the bone marrow sample, which started with a myeloma tube. So here you can see that there is a cluster which is in the dim CD45 area, which is expressing both 38 and 138 along with 319, and these are the markers of plasma cells. So confirming that these are plasma cells again, which is showing kappa light change restriction, and these cells were negative for 56 and 19, again proving that it's abnormal. And there was variable 81 expression, however 117 was negative. But we can see that at the same time, the lymphocytes which are here, which are CD19 positive, which is given a green color, is showing both polyclonal kappa and lambda. So the plasma cells which were there, which were showing abnormal immunophenotypic expression in view of kappa restriction, loss of CD19, dim CD45, etc. And the corresponding B lymphocytes over there showed a polyclonal expansion. And this cluster was about more than all the plasma cells, that is the gated plasma cells, more than 95% were abnormal, and thus we concluded to a diagnosis of plasma cell neoplasm. And subsequently we had done a peripheral blood flow in the peripheral blood also. Again, it also showed a typical cluster in the CD45 dim region with the immunophenotypic findings as elicited in the bone marrow, where there's a good cluster of 38 and 138, again with loss of CD19, dim 45 and kappa restriction. And it was again showing a variable 81 with absence of 117 and 56. So we concluded it as a diagnosis of plasma cell leukemia, and CD56 absence is commonly seen and associated with the plasma cell leukemia. So the flow cytometry confirmed that along with the morphology immunotypic profile, we concluded to a diagnosis of plasma cell leukemia. So again, we had done a screening tube markers as well, just to ensure that there is no abnormal B lymphocytes or T lymphocytes in the in this plot, and as well as the immaturity markers are also absent in this plot. So this was a flow plots. And now again, since this plasma cell leukemia was the diagnosis, it was again evaluated with the myeloma biochemical parameters, which showed that FLC kappa nearly of 2150 milligram per DL and lambda 11 milligram per DL, kappa lambda ratio more than 100, and immunoglobulins of 609 milligram per DL, IgM 6.8 and IgA of 13.3 milligram per DL. But SPEP did not reveal any MP. expand. So meanwhile, the hepatology, since the hepatic encephalopathy was also worsening, the hepatology team had advised a liver biopsy, and which was done. So by this time we received the bone marrow biopsy also. So there lied the pathology of the disease again, another pathology as well. So this, we can see that it was an adequate core and the spaces were adequate. It again showed monotonous population of cells, which is embedded in a eosinophilic acellular amorphous material. On this higher power view, this shows that these mononuclear cells were sheets of plasma cells lying throughout the marrow, which was embedded in this interstitium, which was showing, and the perivascular areas which were showing acellular eosinophilic amorphous deposits. And so hence we concluded morphologically that it was a plasma cell neoplasm along with the amyloid deposits. So IHC profile in the bone marrow again showed a CD138, which was highlighting the sheets of plasma cells and exhibiting kappa light chain restriction, and CD19 and CD20, which are the pan B cell markers, which was also negative in this, confirming that there was no underlying lymphoma. It was solely the plasma cells which was causing these clinical features. And we had repeated we had done a bone marrow Congo red on the bone marrow biopsy. It showed that all those interstitial and perivascular areas were showing congophilic material, and this is under polarizing microscopy, which was showing an apple green refringence. So we concluded that this was also the amyloid deposits was confirmed by this Congo red stain. And subsequently we received a liver biopsy also. So the liver biopsy again showed an adequate liver biopsy, which was showing widened tracts. Tracts were very widened, which was showing again homogenized hyalinized material, which was surrounding the vessels and the ducts. And even the lobules also showed the deposition of pale homogeneous material around the trabeculae, in view of which we again did the Congo red stain on the liver biopsy. So the liver biopsy Congo red was also showing the apple green congophilic material throughout it, and which was exhibiting again an apple green birefringence under polarizing microscopy. So the liver biopsy was also concluded as a deposition disease favoring amyloidosis, and the sinusoids were showing few large mononuclear cells. Though we attempted IHC on that, it was non-contributory. So this is how we concluded that the patient was having plasma cell leukemia along with amyloidosis, and that's how our title holds on. That is the dual heads of Hydra. The single plasma cell is causing the two types of disease in the same patient. Now I hand over to Dr. Gogol for further discussions.
For this patient, here further evaluated, admitted under liver ICU, we are seeing as consultation. And he was started on dexamethasone and bortezomib, which dose was reduced at 0.7 mg per meter square, considering his liver function. And it was given for weekly for 2 weeks. Meanwhile, he was having a sepsis with a blood culture positive for Klebsiella. And after 2 weeks, his hepatic encephalopathy worsened. And finally, he died. We couldn't save the patient. So we'll be discussing the further case, the plasma cell leukemia with amyloidosis. And initially, the plasma cell leukemia, as per the old diagnostic criteria put forward by Kyle in 1974, it was about more than 20% of plasma cells in the peripheral blood, with the absolute count more than 2 into 10 raised to 9 plasma cells in the peripheral blood. Later, IMWG has revised the diagnostic criteria to more than 5% of circulating plasma cells in the peripheral blood smears. Here, please note that we are not using the flow cytometry. It is only based on the morphology of the plasma cells in the peripheral smear. So plasma cell leukemia can be a primary plasma cell leukemia or a secondary plasma cell leukemia. Most common is a primary plasma cell leukemia that contributes to around 60 to 70%. That occurs at de novo. And a secondary plasma leukemia, that is usually a transformation from the multiple myeloma, that contribute about 30 to 40%. So diagnosis required, a confirmed diagnosis of multiple myeloma along with a plasma cell more than 5% of WBC on peripheral smear. Usually the differential what we have discussed earlier, it should be a leukemia or a lymphoma. Usually it is unfavorable compared to a multiple myeloma, and usually primary plasma cell leukemia is seen in younger patients and having a more advanced international staging system. Usually they have organ involvement, hepatomegaly, splenomegaly. There will be extramedullary disease, renal failure, hypercalcemia, elevated LDH, thrombocytopenia, elevated plasma cell labeling index that usually shows an aggressiveness of the disease. So this is an article published in Leukemia Journal in 2008. Here we can see the age of the patient compared to the multiple myeloma, secondary plasma cell leukemia, and primary plasma cell leukemia. The plasma cell leukemia patients are having a lesser age, the 54.5, the median between 31 to 82 years with a significant p-value. And also we can see the organomegaly. They have mentioned splenomegaly and hepatomegaly. Among that, hepatomegaly was significant p-value as 0.04. And we can further see the aggressiveness of the disease, like there is a severe thrombocytopenia, then creatinine rise, then hypercalcemia, and elevated liver enzymes also. The diagnostic workup is usually similar as that of multiple myeloma, that we are doing the peripheral blood smear, CBCs, then immunoglobulin level, heavy chains and light chains, LDH beta 2 microglobulin, then serum and 24-hour urine protein, electrophoresis, immunofixation, bone marrow study, including fish, and PET-CT to see for any extracellular plasmacytoma status. And if the CNS is suspect, normally suspect, we have to do an LP also. For this patient, we couldn't do a fish study as a patient having a financial constraints. We could only do the bone marrow aspiration biopsy. So, coming to the prognosis of plasma cell leukemia is poor. That's it is worse than the high risk multiple myeloma. The following Kaplan curve was taken from the secondary one journal that's published in the Blood Journal 2023, and we can see that a comparison of primary plasma cell leukemia with a secondary plasma cell leukemia, where the primary plasma cell leukemia has a better overall survival with a significant p-value. And the next figure is that comparison between the year of diagnosis, they are divided between the less than 2023 and more than 2023. So when the diagnosis was confirmed more than 2023, 2013, along with the primary plasma cell leukemia, they have better overall survival with a significant Next, coming to the comparison between a secondary and primary plasma cell leukemia, we can see that the progression of the disease or the response and median progression-free survival, the median OS or the median post-stem cell transplant survival. These are significant in case of or better in case of a primary plasma cell leukemia. And this is another study that was published in VG Heme Journal. Here they have done a multivariate analysis. They were able to find out there are some independent predictors that can predict the worst survival. Most of the controllers age more than 60 years, thrombocytopenia platelet less than 1 lakh, and the peripheral blood plasma cell count more than 20 into 10 raised 9. So they have divided based on risk factors given as 0 to 2 and median OS was 46 months in case of there were no risk factors. When there was 2 to 3 risk factors were there, median OS was 12 months with a significant p-value. Now coming to the genetic aberrations usually seen in the plasma cell leukemia, we can see IGH translocations. There are common in primary as well as secondary plasma cell leukemia, and there's TP53 mutations, again, either mutation or deletion. These are all common in case of a plasma cell leukemia, and 13q deletion is common in primary plasma cell leukemia. And when considering the overall survival in primary plasma cell leukemia, uh, c-MYC mutation breakup are not significant with a p-value of 0.006. And coming to the secondary plasma cell leukemia, p10 deletion was having a worse prognosis. So these have plasma cell leukemia have a different cytogenic abnormality compared to the multiple myeloma and secondary plasma cell leukemia. Usually they present with a complex or hyperdiploid karyotypes. Hyperdiploidy usually have a favorable prognosis in multiple myeloma, is rare in primary plasma cell leukemia. Other usual combinations are deletion of 17p, translocation 1114, translocation of 1416. And chromosome abnormalities are more common in plasma cell leukemia than in multiple myeloma, and usually they are more frequent in secondary plasma cell leukemia compared to the primary. TP53 usually signifies more, it's more common in primary plasma cell leukemia, and it's in more double hit profiles. And prognostic impact, they have a inferior overall survival and PFS also in primary plasma cell leukemia. Coming to the treatment, usually these patients should have a supportive care will be that the chance of tumor lysis is more, so there will be adequate hydration, hypercalcium will be there, so hypercalcium management, everything should be done. Coming to the proper treatment, there should be just like for multiple myeloma treatment, there should be induction therapy, then followed by a consolidation with autologous stem cell transplantation, and followed by maintenance. So these are a few statements regarding the role of proteasome inhibitors that having a higher overall response rate demonstrate up to 79% in some retrospective studies. Then IFM phase 2 study has shown adding a bortezomib, dexamethasone, cyclophosphamide, and anthracycline yielded around 69% of the overall response rate in newly diagnosed patient. And this bortezomib may abrogate the adverse prognostic association with the high-risk cytogenesis seen in the primary plasma cell leukemia. The second generation of proteasome inhibitors, including carfilzomib and ixazomib, has shown a higher efficacy. And the EMN12 or HON29 study also showing KRD regimen as a early response in primary plasma cell in leukemia induction. Coming to the immunomodulator drugs, lenalidomide, which was shown in a phase 2 study that 60% overall response when lenalidomide was combined with dexamethasone, followed by without high dose melphalan and autologous stem cell transplantation. Next generation immunomodulators include pomalidomide, which has shown high efficacy. A combination of pomalidomide and proteasome inhibitors and immunomodulators, RVT regimen, these can be considered frontline. And treatment duration, usually the induction regimen we are considering based on the transplant eligible or ineligible. If the patient is ineligible, usually we go for 8 to 12 cycles of induction followed by maintenance. Transplant eligible patient will go for the induction around 6 cycles and followed by transplant. And coming to the role of chemotherapy, so if the patient is usually intensive regimen, if the patient is fit, is considered for rapid site reduction, their VDT pace or hyperCVAT combining with the lenalidomide and bortezomib can be tried. And frail patients, you can try with the RVD plus liposomal doxorubicin or RVD plus cyclophosphamide. Coming to the CD38 directed monoclonal antibodies, daratumumab, this is highly efficacy in multiple myeloma, and some studies have been trying using of primary plasma cell leukemia and their combination along with lenalidomide, bortezomib, dexamethasone, and daratumumab. Even carfilzomib contained regimens were also tried. So have a better response. And emerging combinations including pomalidomide and ixazomib, daratumumab, bortezomib, dexamethasone, liposomal doxorubicin, and lenalidomide. In patients with translocation 11-14, there was, especially in multiple myeloma patient, ventroclass BCL2 inhibitors use was shown to have better response. So this can be applied to plasma cell leukemia also. Role of autologous stem cell transplantation and phase 2 trials and registered data says that autologous stem cell transplantation with combination of a proteasome inhibitors and immunomodulators may be effective in some patients. And we can see that with the advent of the treatment, better treatment outcome we are getting. So there are between the data, previous data was showing a lesser overall survival. When coming to the recent years, we are seeing a better overall survival with the autologous stem cell transplantation. So EBM data between 1980 to 2006, which are showing a PFS of 14.3 months, the overall survival of 15.7 months. And CIBMTR data, PFS of 34% and 3-year overall survival for 64%. So they are found to have a better OS with tandem autologous stem cell transplantation. Then role of allogeneic stem cell transplantation, this found to have a lower lapse rate at 3 years when compared to autologous stem cell transplantation, but they have inferior 3-year overall survival rate due to the higher treatment-related mortality in allogeneic stem cell transplantation. And these patients tend to have a longer term remission. Usually the survival plateaued around 20% at the 5 years. And the tandem autologous and allo transplantation showed a median PFS of 15.1 months and overall survival of 36.3 months in patients with less than 64 years in IFM trial. And if you're planning for a transplantation, that should be offered early. Then after, like, better to do it early than waiting for a relapse. And the reduced intensity condition may reduce the TRN, but the relapse risk is high. Then tandem autologous allogeneic stem cell transplantation that should be considered in some prospective studies for optimal cytoreduction and graft versus myeloma effect. So maintenance therapy, the plasma cell leukemia is usually aggressive. So they will have an early relapse. So there will be should we have there's necessity early maintenance or consolidation. Single agent usually N maintenance alone will have a high relapse rate. So doublet or triplet consolidation may improve the overall response rate and progression-free survival. And post-allogeneic stem cell transplantation maintenance, usually enaldomate can potentially increase the chance of acute GVHD. So lower dose may be tried. Both is safe and feasible. In relapse rate, it is limited data based on guidelines are limited. So usually we follow a multiple myeloma based regimens, combination of active multiple myeloma drugs and retreatment, consider treatment with the prior effective regimens or for deep and prolonged responses. Then sequential novel agents can be added, a combination of drugs can be added. So salvage strategies include pomalidomide, panobinostat, letrozumab, daratumumab, isostimab. So this usually a combination of drug is tried along with the bispecifics also. Chemotherapy combination can be also tried, which also remain as a potential mainstay when with along added with high dose steroids and non-neurotoxic agents like thalidomide. So in our patient, he was having a rapid deterioration of the liver failure. So we were searched regarding literature, any other similar reports are there. So there is one case report that is published in World Journal of Gastroenterology. Here they have mentioned about the hepatic failure caused by plasma cell infiltration in multiple myeloma. Here they have mentioned that around 45% of the patients with multiple myeloma at the time of autopsy will have a plasma cell infiltration, but usually it will be mild. So that can be a form of a light chain deposition in the liver. There can be extracellular plasmacytoma. There can be amyloidosis or a diffuse infiltrative pattern. Usually it is mild. So there are some few cases which have a rapid and massive plasma infiltration, which can lead to a cholestatic, non-obstructive cholestasis, which can progress into liver failure. This may be the cause that our patient also had a progressive liver failure and worsening of hepatic encephalopathy. Plasmacytomas in liver is less common. It can be usually found out in the imaging through imaging we can see. And amyloidosis can be seen in 15% of the general multiple myeloma patient population. Now, coming to the second part, the plasma amyloidosis. So, amyloidosis is due to the abnormal protein deposited in the extracellular space that is caused by the misfolding of proteins that differs on the site of deposition and type of protein that is deposited. Can be due to a neoplastic etiology, primary amyloidosis, or inflammatory or a hereditary or idiopathic condition. This protein deposition leads to an abnormal function of the organ, which leads to an organ death, organ failure and death. Organ dysfunction can be due to architecture distortion caused by deposition of these proteins or as cytotoxic effects of this protein. Most common is a light chain amyloid, AL amyloid. It's a primary amyloidosis. This following table is taken from Harrison Principle of Internal Medicine. Here we can see the different types of proteins, approximately 42 types of proteins they are deposited, and each depending on the site of the deposition, site of the organ which is involved, that can have different names. So here we are concentrating mainly on the primary amyloidosis that is shown in that red box, AL amyloidosis that you should have an immunoglobulin light chain, and very rarely can be a hemoglobin heavy chain, AH amyloidosis also. So the following diagram is taken from the New England Journal of Medicine, where the pathogenesis of AL amyloidosis is demonstrated. You can see abnormal plasma cells that is producing the antibodies, the free light chains are there. These light chains are misfolded and they form the chains to a oligomers that aggregate from beta amyloid fibrils. Once these fibrils are formed, these get deposited in the extracellular spaces, especially if it is getting deposited in the cardiac muscle, they are shown in the figure, can lead to displace the healthy tissue and cause difficulty in the contractility, can lead to a cardiac failure, or it can activate a reactive oxygen and lead to apoptosis also. There are in the diagram there are mentioned two things to target the therapy. One thing is decrease the plasma cell that we have already we are discussing about the plasma cell leukemia to target the plasma cells, and another is antibodies that can act against this fiber that will come in the few slides. So most common type is a light chain, lambda light chain that contributes to around 75 to 80% of these amyloids, and kappa is seen, kappa light chains are seen in 20 to 25%. A translocation of 1114 is seen in 50% of these cases, and hyperdiploidy, which is most commonly seen in myeloma, is observed in approximately 10% of cases of AL amyloidosis. Then genetic study, there are few mutations, germline gene mutations, especially IGLV V657, that can have a kidney manifestation more, and this IGLV V144 that have a cardiac manifestation, and IGK V133. These mutations will have a kappa light chain and predominant mutation targets in the liver. Our patient have a kappa light chain elevation, and the majority is involved in the liver. Because we have screening echo was done, there was no evidence of a restricted cardiomyopathy. This demonstration is also taken from the New England Journal of Medicine. Here we can see the common presenting features of the patient. Usually, patient have a non-specific complaints like fatigue and weight loss. This is the major reason why amyloidosis is often being diagnosed very late. So when the patient presents with a non-specific fatigue and weight loss, nobody will be thinking about a systemic amyloidosis or light chain amyloidosis. The kidney involvement is around 60 to 70%, and heart is affected around 70 to 80%, and it's the leading cause of death. The general examination features were striking, or maybe patient will have a macroglossia, and there may be a raccoonase or a periorbital ecchymosis may be there. Then maybe submandibular gland enlargement may be also seen in some patient. And heart will have usually have a restricted cardiomyopathy, heart failure with preserved ejection fraction. That can be as left ventricular hypertrophy, hypotension, dyspnea or edema. Lung will have a pleural effusion, most probably secondary to the reduced cardiac output. And kidneys may have a nephrotic range proteinuria, nephrotic syndrome, kidney failure. Then GA tract will have a GA bleeding. Then there may be protein losing enteropathies also. Then maybe amyloid and arthropathy. Then acute factor 10 deficiency that lead to bleeding. Then autonomic nervous system involvement leads to orthostatic hypotension, GA motility issue, erectile dysfunction, and peripheral nervous system involvement causing sensory neuropathy. So the patient can present to so many departments, like they may be presenting to the cardiology, they may be screened for an echo. Unless uh, we are concentrating like this should be a cause, like our cardiologist or a nephrologist who are thinking that amyloid is a possibility. Unless we are not thinking that such a possibility, usually these cases are missed. So the following table is taken from NCCN guidelines, like guidelines for systemic light chain amyloidosis, including the workup. Usually the workup is similar to that of a multiple myeloma. Then we have a cardiac bone marrow study will be there, including fish. Then apart from that, there are a few things. One thing is electrocardiogram. Usually ECG, which it should be showing a low voltage composite, will be discussing later. Then echo will have the longitudinal strain, and there maybe we have to do a fat pad sampling extra, and amyloid subtyping that using a mass spectrometry. Then this lymphoplasmatic clone that we have already discussed in the flow, we have to able to differentiate. And apart from that, that's organ specific things we have to do. We have to see for the NT-proBNP troponin T levels. That is usually we are using the Mayo staging to grade the involvement of amyloidosis. Then kidney involvement, we have to go for this 24-hour urine protein. And liver, usually if the substructive pattern is there, ALP is elevated, liver enzymes should be elevated. Then as we had discussed in the previous slide, factor 10 levels can be decreased. So coagulation study is also indicated. So what will pattern or the algorithm that we are using here is, first, if the patient is suspecting an AL amyloid or present with AL amyloidosis, we have to go for a immunofixation of serum and urine and serum free light chain assay to find out is there any involvement of light chains are there. If it is negative, usually AL amyloidosis is unlikely, so we have to screen for other type of amyloidosis. If it is positive, we have to go for subsequent biopsy. Usually, we'll do bone marrow biopsy along with a fat pad biopsy or a rectal biopsy, where we can stain for Congo red stain. And if it is positive, we'll see for a systemic involvement. If it is negative, again, we will have a high index of suspicion. We have to target the involved organ. So maybe if the kidneys are, we are suspecting a proteinuria, along with we are having a high light chain as ratios are there, then we have to go for the biopsy of that target organ kidney. And if it is the systemic involvement is there, we have to confirm the light chain amyloidosis. That confirmation of light chain amyloidosis is usually by using a mass spectrometry. And if it is uncertain, we have to go for the genetic study and other specialized testing in referral centers. So this following table is taken from New England Journal of Medicine. Here we can see the different classification used for grading of staging system for IL amyloidosis. Usually we follow the Mayo 2012, which includes values of troponin T and NT-proBNP. That is usually the cardiac markers. And another one is a difference in the free light chain, more than 180. That reflects the plasma cell load. So depending on the values, there are the stages from 1 to 4, and overall survival is differing. Like stage 4 is very serious, and overall survival will be less. You can see the hazard ratio also here 6.3 when there is stage 4 with 3 markers, above markers are abnormal. And similar to that, there are so many other classifications, especially Boston classification, which mainly concentrate the liver parameters alone, and the renal staging also they have put forth depending on the creatinine clearance. So coming to the biopsy, so surrogate biopsy, usually we have already discussed, like if you are suspecting a light chain amyloid and the light chains are elevated, we can go for a less invasive procedure like fat pad biopsy, then bone marrow, then skin biopsy. These are the surrogate sites. And this target biopsy is the symptomatic organ like heart, kidney, liver, peripheral. So this table we have adapted from the ASH 2024 meeting in San Diego. Here you can see that first two things, fat pad biopsy and bone marrow biopsy, these are usually surrogate biopsies, and the yield is around 76 in for fat pad and bone marrow 55. Combining both, that fat pad and bone marrow biopsy will have a sensitivity of 89%. And all other things, the peripheral nerve, then liver, GI, kidney, and heart, these are sort of target organ biopsies. And among them, kidney and heart have the higher yield. This is another on retrospective study. They have combined rectal and the skin or fat pad biopsy in biopsy poor renal amyloidosis. Here they were able to demonstrate that 99% of sensitivity when combined rectal plus skin or fat pad biopsy. And mass spectroscopy will have an 89% sensitivity and the specificity is 96%. So this is a ECG which is usually showing a low voltage complex in the patient involved with amyloidosis. And the next picture is showing the hypertrophy of the left ventricle. Echocardiogram, usually when we are using the longitudinal strains, we can identify restrictive cardiomyopathy, and Doppler techniques also help to find out this longitudinal strains. Then cardiac MRI, especially identify the myocardial thickness and contrast-led contrast enhancement. Then extracellular volume also will help to identify. In cases of if there is a cardiac involvement, we are not, but the light chains are low, the bone marrow plasma cell, we are not able to demonstrate a plasma cell involvement. So another possibility of ATT cardiac amyloidosis there. There, your scintigraphy or a technician scan will be more useful. Treatment is consists of mainly targeting the plasma cell to reduce the protein production or reduce the protein production. Or next one is individualized therapy, because so many patients have the involvement of different organs. Suppose the heart involved patient will have a problem in dyspnea, more of a edema, pedal edema, orthopnea. Then as a low cardiac output, hypotension. So this therapy should be individualized for the patient, especially our patient will have a hepatic involvement. We have to reduce the dose of bortezomib. And other thing is we have to produce the organs of specific supportive care. So increase the maximum quality of life. These are the main treatment we are aiming at. So supportive therapies in AL amyloidosis, usually if the patient has fluid retention, we have to hike up on the diuretics and reduce the salt intake. And orthostate hypotension, behavioral modification, high thigh stockings, melatonin. Then neuropathies, there we can start with gabapentin and pregabalin. Then diarrhea, we can use loperamide. Then malnutrition, giving the nutrition supplement, renal failure, dialysis, or kidney transplantation, selected cases. Then heart failure, using loop diuretic, then salt restriction. Then we can use implantable pacemakers. Then bleeding manifestations, there you can use FOP or recombinant factor 7E and prothrombin complex concentrate. These are the usual use for the subtopic care. And next, coming to the systemic therapy, this recommendation from the NCCN guidelines. Usually, if there is no significant neuropathy, stage 1 to 3A, this is based on the Mayo 2004 staging. Cooperative therapy is preferred as a first line, using daratumumab, cyclophosphamide, bortezomib, and dexamethasone, and autologous stem cell transplantation followed by this induction regimen. If patient is unable for a stem cell transplantation, bortezomib, melphalan, and dexamethasone. And some patients are avoiding the daratumumab like cyclophosphamide, bortezomib, dexamethasone can be also tried. And stage 3B, dose modified daratumumab, cyclophosphamide, bortezomib, dexamethasone. So or single daratumumab may be also tried. If there is significant neuropathy, usually we have to come down the dose of bortezomib. Daratumumab, cyclophosphamide, again the quarterly regimen is preferred. Then melphalan and dexamethasone if the patient is ineligible for stem cell transplantation. And in certain condition, we can try with lenalidomide dexamethasone or a carfilzomib dexamethasone. Now coming to the antibody trial, so this trial demonstrated the use of daratumumab. So they have made a randomization of the 330 patients. AL amyloidosis more than one organ involved. There is no prior therapies of AL amyloidosis and cardiac stage based on Mayo staging 1 to 3A and GFR more than 20 ml per minute. And this randomization, they divided into two groups. One group was given dara with cyclophosphamide, bortezomib, and dexamethasone. Another group avoiding the daratumumab, cyclophosphamide, bortezomib, and dexamethasone. And they were observed till there is a major organ deterioration. The primary endpoint was an oral hematological CR, and secondary endpoints were organ response rate, major organ deterioration, time to hematology response, and OS. So they were able to demonstrate that the hematology CR was 53% when compared to 18% in cyborg exam, but adding the DARA, that came to 53%. So response to DARA cyborg was deeper and achieved more rapidly. And then subgroup analysis, this is a forest plot. They were able to demonstrate the role of DARA in achieving the hematology response, which was consistent in all the subgroups. If there is well, 11, 14 is present, mutation fish is present, then cardiology staging in all stages, 1 to 3, they are able to demonstrate that DARA cyberdeath was favorable. And overall response also, it was higher, 92% overall response compared to 77% and the significant high response was seen with DARA cyberdeaths. Stem cell transplantation, when the transplant, they compared between this, it was from the journal of bone marrow transplantation. They had compared with the patient who had deferred autologous stem cell transplantation with an early autologous stem cell transplantation. They found to have a better overall survival in patients who have done an early autologous stem cell transplantation with a significant p-value. When considering the patient for autologous stem cell transplantation, the careful patient selection is the better. And autologous stem cell transplantation can be deferred if hematological CR is achieved with induction therapy. Prior to stem cell transplantation, consider induction therapy, and post stem cell transplantation, consolidation and maintenance are not routinely recommended in light chain amyloids. So, usually, considering patients for autologous transplant is age less than 70 years with a good performance score, less than 2 major organs involved. With next, the troponin levels less than 0.06 is significant, less cardiac involvement, a creatinine clearance more than 30, significant less renal involvement, and systolic BP more than 90, NOHA function class 1 or 2, and NT-proBNP less than 8,500. That means there should be patients screening should be done before selecting for autologous stem cell transplantation with good performance score and less organ involved should be aimed. And definite exclusions of autologous transplantation is from NCCN guidelines that the patient who have symptomatic or medically refractory ventricular arrhythmias or arterial arrhythmias, pleural effusion, uncompensated heart failure, then orthostatic hypotension refractory to medical therapy, then factor levels 10 levels less than 25 or evidence of active bleeding, extensive GA involvement evidence of active GA bleeding. These patients should be definitely excluded for autologous stem cell transplant. These are the future therapies or ongoing trials that is going more or the monoclonal antibody based trials are going, then even CAR T based trials are going, then bispecific agents are also going. So these trials usually they are for newly diagnosed and relapsed refractory cases, and the completion year is 25, 26, 27. Like within a few years, we'll get the results of these trials. This is a similar spot. They are used when patient with cardiac emergency is treated with a teclistamab. They have evaluated for 7 patients. We can see that most of the patients achieved VGPR very early within 2 months. And among the 7 patients, 6 patients have achieved CR also. This is the landscape of AL amyloidosis, like initial treatment in 1990s, starting from milk to high-dose stem cell transplantation, with having a more survival than 68%. Then coming to a recent 2020, starting of DARA-based SARA Diabetes and clinical trial is having a 78% VGPR. Then even close to 2025 introduction of CAR-T and bispecific antibodies which having EGPR, and this treatment is evolving, and then can have more agents in the future. So for our patient, he presented with plasma cell leukemia and the liver involvement also, the hepatic encephalopathy, worsening hepatic encephalopathy, and amyloidosis. This plasma cell had presented with the 2 phases, like one is a plasma cell leukemia, another is amyloidosis. And we were able to start the medicine, and we were not able to for the medical antibody, but we were started on dexamethasone and bortezomib also, based on this liver function dose modification was given, and it was given, but this had a bad sepsis and worsening hepatic encephalopathy. We were trying with the hospital team what else could be done with the liver transplantation, especially case of worsening hepatic encephalopathy, acute liver failure, with the liver transplantation for the trial. But since he was having this 45% of atypical cells, it was unlikely to would benefit from a hepatic transplantation, liver transplant. Other possibility we tried, like whether a plasmapheresis could benefit him and reduces ammonia levels to reduce hepatic encephalopathy. That also improves bad sepsis was deferred. So, by this, we are concluding our presentation and the 2 phases of plasma cell. To me, sir.
Thank you so much for that presentation. So now, Neeraj, would you like to say your final comments before I hand it over to Dr. Joseph to take the session forward with the Q&A?
Yes, thank you, sir. So thanks, Gopal and Meera. So this patient was in every way having a very atypical presentation. First of all, we got a consultation from a liver ICU for a patient who has hepatic failure and hepatic encephalopathy and with a hypercalcemia. The odd point here was hypercalcemia. So, and leukocytosis, patient was in sepsis. So first of all, we least expected, hematological malignancy before we saw the calcium. Second, once we saw the, peripheral smear, initial thought was maybe it's a high-grade lymphoma or leukemia, and resources were limited. So it was a calculated miss not to do the fish because, we expected it to be a leukemia or lymphoma. But then even the morphology was not at all typical of a plasma cell in the peripheral blood, although he had a plasma cell leukemia finally when we did the flow cytometry. The manage so and then we were even in for more surprises when we did the liver biopsy and the bone marrow biopsy, both showing in addition to the plasma cell infiltration, the amyloid. So this was indeed very strange, because one is you are expecting a high grade malignancy like a plasma cell leukemia on one side. On another side, to our general understanding, amyloid is a slowly progressing disease, and it takes years and months and years for amyloid to manifest. So if I look at Gopal's history, it's about 2 months. It's what we got from his wife, that he was unwell for about 2 months only. So it was puzzling. What is the natural history of this disease? Even plasma cell leukemia would have been very acute, but then how did the amyloidosis come? Can amyloidosis happen acutely, or was he having amyloidosis for some time? So we have not been able to answer that. Then the question is about the patient having, patient, once we diagnose plasma cell leukemia, obviously we want to start treatment, but we were never able to start treatment appropriately, although we gave bortezomib and dexamethasone. He had sepsis and he was not in a good performance score at all. Patient is comatose, tuberous, and has, more importantly, features of liver failure and um, and hepatic encephalopathy. So, I mean, as Gogol mentioned, we were also thinking, resources were limited, but if the resources were unlimited, could we salvage the patient by maybe doing some plasmapheresis, or what about a liver transplant? Would that help? These were all questions that we had in our mind. Unfortunately, we still have more questions than answers.
Thanks, Dr. Neeraj. Dr. Joseph? Okay, so while
Hi. Sorry, I got a little late in joining. I'm
No
seeing
problem.
the question there in the question answer box. There is one question there of the role of using doxycycline in amyloidosis
Okay.
when a chemotherapy background. So, any role of uh, doxy?
So I think there is some evidence for the long-term improvement with doxycycline, especially those patients who have a cardiac light chain amyloid. However, I think I think now, um, uh, in a chemoimmunotherapy, the question is specifically for a chemoimmunotherapy background. So I suppose it's about when you give daratumumab with Cybor D, that as Gogol just presented the data on, when you add daratumumab to Cybor D, the response rate is tremendously deepening, and so the differences are vast actually. So and that trial did not include doxycycline. So I think
Okay.
I think that's all.
So, shall we take home saying that if they can afford to give DARA and VCD, then no need to consider doxy? But let me ask you our question. Suppose that is not feasible or not affordable, would you then throw in doxycycline as a, some measure?
I think the data. So what we have seen is data has excellent initial response, especially the light chains, come down with even lower doses of daratumumab. So, I would say that some dose of dara versus no dose of dara would be still,
A smaller dose.
uh,
Smaller dose. So even if you can't afford, get somehow put in some dose of DARA there.
yeah.
Okay, so DARA with CNS penetration, any data on that as of now?
I'm not sure.
Not sure. So there's another question about liver involvement. The question Dr. DS is asking is liver involvement is usually late with such extensive involvement with decomposition. What are the drugs which decompensation? What could be the safe options here among the choices we have?
Yeah, so I think it was a tough call. Again, what all drugs we could give in liver decompensation. So bortezomib obviously can be given, but it needs dose modification. I think Gopal just mentioned that we gave 0.7 milligram per meter square for bortezomib, and we gave dexamethasone also. We could not give cyclophosphamide. And then daratumumab, I think we could still give, but again, we were not able to give daratumumab in this patient.
Today, I understand that probably your center is the best, most advanced in amyloid detection now. So, what is the extent to which we can diagnose amyloidosis in India today, and what are the options available in the, abroad if we can send?
So I think we have, I think like Gokul mentioned, mass spectrometry is the key to subtyping. So the first is regarding diagnosis. Of course, the patient presents to different specialties, and we need to have a high index of suspicion. A patient who presents to cardiologist, with cardiac failure, and you have normal coronaries. I think we should, suspect, is something, is there something which we are missing, and especially if you have two things in the opposite, is what our cardiologist says. If you have a low voltage ECG plus if you have a hypertrophic LV, both in the opposite direction, then you should start worrying about if it's amyloid. Likewise, in many specialties, where patients present with proteinuria, so proteinuria, peripheral neuropathy, carpal tunnel syndrome. So the picking up at the time they present is one of the important things I feel. Second is, of course, once you have a clinical suspicion, and then proceeding with a light chain, and of course, and see if the light chains are restricted, will tell us whether it's a light chain, likely to be a light chain amyloid. And more importantly, when you go for a biopsy, what site are you going to biopsy? If you see an abnormal light chains, surrogate site biopsies are safer, especially the bone marrow and the fat pad, and sometimes rectal. But if you're not able to do the surrogate site biopsy, then target site biopsies like liver, kidney, and the myocardial biopsies can be done. So these all can be done. But if light chains are not restricted, but still you have a myocardial imaging saying that it is likely to be amyloid, then you go for a technetium pyrophosphate scan. It may be ATTR amyloid. The ATTR is almost as common as AL amyloid, but it's probably not picked up. So, and then I think we have the tissue type, and then over a period of time, the expertise is developed by the pathology team in picking up the Congo red, the eosinophilic deposit in the Congo red, and that should be an easy job now. Now, coming to the question that you particularly asked about the typing and whether we should send it abroad now, I think it is available in India now. One of the, I think the Lalpath Labs has already introduced mass spec amyloid typing. Probably more people are going to offer it now, and then let us see. We probably will be able to diagnose more.
Okay, so that is all. There are a few more questions which have come. Any role of venetoclax, as some of the amyloids majority may have 11-14 translocation?
I think yes. Majority of one of the things, when you have a doubt whether it's an AL amyloid, is to pick up the or it's an MGUS, is to if you have a 11-14, and that will add value to your diagnosis or suspicion of amyloid. We know that venetoclax data from the multiple myeloma, that it's an agent which can be used successfully in 11-14.
So would you bring it up front, or would you save it
no,
for later?
No, save it for later.
Okay. So second question is I want your algorithm. Suppose the pathologist says either kidney biopsy or as lab, fat pad or a rectal biopsy or a marrow shows amyloid by Congo red. We do a restriction IHC and find that it is kappa or lambda or CD38 is positive. When would you want a mass spec to be done?
So it's like if we have a light chain restriction, let's say the kappa lambda is 100 and the kappa is 10, and then there's a light chain difference of 90. And if we have a tissue that has shown amyloid, and I would say which tissue, if it is a renal tissue, a kidney biopsy, then you have immunofluorescence, and the immunofluorescence will very well show the light chain restriction there.
Sure.
So in that case, you don't need a mass spec.
Sure, mass spec.
Yeah, you don't need a mass spec. But if you have a cardiac tissue or a fat pad tissue there, you would need a or any other organ, you would need a mass spec to confirm it.
Okay. And have you been using mass spec or sending it to Achlekar whenever required and got, biopsies proven other than light chain amyloid?
Yeah, so we have, I mean, we have been out. I mean, we have done a few mass specs in house, but that's still in the development stage, I would say. So I think there are a few centers which is offering mass spec outside India. I mean, now it's available in India, but then Bachelor's lab is one, and then we have Toronto General Hospital, and then Mayo also. These are the centers which we can do mass spec, and then sometimes we have, we've had very interesting. You mentioned IHC, so we had a patient where the IHC was suggesting SAA, and needed the mass spec out because our clinical correlation was not there, and it turned out to be AL amyloid by mass spec. So
am I right in saying that I read somewhere in one of the groups that the cost is around 60,000? Is that right? Or
I
for
think
doing an outsourced aspect?
it's beyond that, but I think in India now they're pricing it around 60,000 is what I think. But
Okay.
I think Toronto it was 80,000 or something. Yeah.
Okay, so over to Dr. Biju if you have any other questions to answer.
So Neeraj, I had just one more question. So I understand this patient was very sick. So you could not do too much. But if you had a patient who was more stable but had sort of a diagnosis of plasma cell leukemia with amyloid, what would have been your sort of chemo treatment plan, including what would have been what is the standard chemotherapy that you would use at your institution, and what would be the follow-up of that?
Okay, so sir, I think I would definitely include daratumumab in the induction regimen. So it will be like, of course, we go for more probably a 4-drug induction. So how would I choose the 4 drugs? I mean, if the patient is quite, organ-wise, if the patient is stable, then I would, or if the patient is unstable in an organ-wise, like maybe, that would be one of the criteria of how I would choose the other three drugs. For example, if the patient is cardiac affected and cardiac stage is stage 3 or beyond, and then I would shy away from chemotherapies like anthracyclines and all that. So a safer induction regimen like Dara VCD would be what I would think in a stable patient who has concerns about organ toxicity. Because amyloid Dara VCD should be a good option, but for plasma cell leukemia, are often very aggressive. So so that
So there, Neeraj, my question would be: would you consider something like VTD pace upfront?
yes, yes. So if the organ function is very good and amyloid has not affected the organ, then and the patient is fit, then maybe a VTD pace with Dara is what I think would be an induction, and of course follow it up with if the patient goes into a remission. Of course, I think I would follow it up with an upfront autologous transplant at least.
Okay, sure. I think we've had a very good presentation and a good discussion. We have gone over time, but that's okay. As long as the discussions happen, it is fine. Now we'll hand it over to Inta. So all of you who are taking part and listening to this, we are going to be doing this every month on usually the third Wednesday of the month, and we're going to have different people. So next one will be from Rajiv Gandhi. Then we've got one from All India Institute. We've got one from Dr. Hemant Malhotra's group in Jaipur. So this is going to be continuing education once a month. And now I'll hand it over to Intas.
Thank you so much, sir. As we wrap up the 4th episode of Blood, the Life Savior, We extend our heartfelt thanks to everyone who made today's session truly memorable. Our deepest gratitude to Amrita Institute of Medical Sciences, Kochi, for partnering with us on this insightful journey into the world of hematology. A special thank you to Dr. Gopal Sinhal for presenting a compelling and complex case, to Dr. Gohul GJ and Dr. Meera M for their sharp clinical insights and dynamic discussion, and to Dr. Neeraj Siddharthan for tying it all together with such clarity and precision. We also express our sincere thanks to our visionary course directors, Dr. Biju George and Dr. Joseph John, whose guidance and leadership continue to elevate the academic impact of this series. To our viewers, your support, engagement, and thirst for knowledge are what fuel Blood, the Life Savior. Thank you for being part of this mission to shed light on the lesser known corners of bleeding disorders. We look forward to seeing you again for the fifth episode on 21st May, where another mystery awaits to be explored. Until then, stay curious, stay compassionate, and good night from all of us at Blood, the Life Savior.
Thank you.
Bye, everyone.
Thank you very
Good night.
much.
Thank you so much, sir.
Thank you.